I'm Dr. Prabodh Karnik, ENT surgeon at the SRCC Children's Hospital managed by Narayana Health in Mumbai. Every so often, I'm asked to see a child who has been born with a deformed ear. When I visit the child, the parents and family want to know whether the child will ever hear. Are there any other deformities in the brain or elsewhere? Will the child ever grow up normally? Will the child get married? So I first examine this child and I want to know whether the deformity in the ear is one-sided or unilateral or on both sides and is it bilateral. I will also see if the ear has a minor deformity with a pinna or the outer ear reasonably well formed and a reasonable outer ear canal, or is it major where the pinna is almost absent and there is no pit or no outer ear canal. I'll first tell the parents and the family not to panic, relax, and tell them that most of these children usually do very well. Presumably, this child has been seen by a neonatologist or a child specialist, and other more serious deformities that may be accompanying the ear deformity have been ruled out, identified. Because if any of them are there, often these take precedence in treatment, and we shall not discuss these patients. I will then order an Otoacoustic Emission or an OAE test. This test, with reasonable certainty, can identify whether the nerve of hearing is good or is it bad. In either case, I will suggest to the parents that this child needs a bone vibrating hearing aid or a soft band hearing aid to be worn on the side which is deformed, or at least on one side in a bilateral case, so that the side of the brain which is responsible for hearing gets appropriately developed over a period of time. In a child with a unilateral ear malformation, if the normal ear has good hearing, we can all heave a sigh of relief. Most often, this child will develop normally, will develop good speech, and can do very well almost throughout their whole life. In a child with bilateral malformation, one has to assume a 50 or a 60 decibel hearing loss. And in this child, we suggest to the parents that the soft band hearing aid must continue to be used so that the child develops good speech. The next time the child is seen is somewhere around preschool, around 3 or 4 years of age. And at this time, a more detailed audiometric examination is performed. At this time, the speech is also looked into and evaluated. And if there's a lisp or poor development of the speech, one suggests to the parents that they are not using the hearing aid adequately enough, because a child will speak only if the child hears, and the child as well as the parents are encouraged to use the hearing aid as much as possible. At this time, a CT scan and an MRI scan are performed with a little bit of sedation. An assessment can be made about the severity of the deformity that is there in the middle ear. Infrequently, the deformity is not much, and surgery can be sometimes thought of to be done in the next few years. At this time, we also introduce the possibility of a bone anchored hearing aid or a BAHA. This involves inserting an implant which is attached in some way to the bones of the skull and using a processor and a microphone which is outside, a reasonable amount of hearing can be given. Of course, this can be done only if the skull thickness is more than 5 or 6 millimeters, and this usually is possible when the child is 5 or 6 years old. Very often, the parents are concerned about the cosmetic deformity, and often I will tell them that by growing the child's hair, camouflage is probably the best answer. But if they so desire, they can see a plastic surgeon who can introduce them to surgery for the deformed ear. While in school, it is important that the child continues to wear the hearing aid that the child is wearing, continues to develop appropriate speech, and at regular intervals, an assessment needs to be made to that effect. During the years of schooling, I would generally tell the parents to tell their wards that they should not indulge in contact sports such as football, karate or boxing, because during these sports, by accident, residual hearing could be damaged. Once the child reaches the age of 17 or 18 years old, and the child can take more responsibility for their own bodies and for their ears, again an assessment can be made whether surgery to improve hearing is possible or not. Do remember that surgery in major congenital deformities of the ear is difficult, it's demanding, and at best, in the best of hands, 60 or 70% results are acceptable. In conclusion, I can say that unilateral congenital malformations or deformities of the ear don't pose much of a problem except the cosmetic issue, which can be either managed surgically or with prosthetics. More often than not, these children grow up normally, develop very good speech, and everything should be okay. Bilateral malformations is a different story, however. The best option for major bilateral malformations is some kind of a bone-anchored hearing aid, so that in the stages of schooling and as a teenager, the child can develop good, appropriate speech. Cosmetic improvement of the ear is a big challenge. Very often, this is a multi-level, multi-staged operation and should be done by an expert plastic surgeon. Most children with unilateral or bilateral deformities of the ear, so long as they are managed appropriately, so long as they accept wearing hearing aids early in life, can lead a very successful, prosperous life.